Priyanna, today I shall record ectopic pregnancy.
Yeah, it's one of 3 topics we're going to talk about hemorrhage in pregnancy. Yes.
Yeah.
Okay.
Causes for hemorrhage in early pregnancy are ectopic pregnancy, hydatidiform mole, then intrauterine abortions. Ectopic pregnancy is one in which the fertilized ovum becomes implanted in a site other than the normal uterine cavity. Incidence 1 in 300 to 1 in 1000 of deliveries, depending on the prevalence of pelvic infections, that is gonococcal, post-abortal, tuberculosis in any community.
So the communities with high rates of gonorrhea and pelvic infections have higher rates of ectopic pregnancy.
Sites. Fallopian tubes is the commonest site. Second, ovary, abdominal, cervical, broad ligament, rudimentary horn of a bicornate uterus. Commonest site is tubal. Tubal pregnancy, etiology. Normally, fertilization occurs in the ampulla of the fallopian tube, and the fertilized ovum migrates to the uterine cavity by the ciliary action of the epithelium and peristaltic movements of the tubal muscle. Factors which are responsible for the fertilized ovum to remain in the tube are factors preventing or delaying migration of the fertilized ovum to the uterine cavity. Second, factors facilitating nidation of the fertilized ovum in the tubal mucosa. Now let us know something about factors delaying and preventing migration. As I have already told, chronic inflammatory disease of the tube in 50% of the cases, like post-abortal, puerperal, tuberculosis, gonococcal infections. These infections cause loss of cilia of the lining epithelium.
The inflammatory process causes death of the cilia.
Yeah. And impairment of muscular peristalsis. Also, narrowing of the tubal lumen can occur. Formation of pockets due to adhesions between mucosal folds. Peritubal adhesions resulting in kinking and angulation of the tube. Developmental defects of the tube like elongation, diverticula, accessory ostia. Distortion of the tube mechanically by fibroid, broad ligament cysts, and ovarian tumors. Now, iatrogenic causes for ectopic. Tuboplasty, intrauterine device, tubectomy. Transperitoneal migration within and external migration, ovum fertilized in the peritoneal cavity and cross the pelvis to opposite side.
So you're saying it could get fertilized here and it could travel over here. Could it ever get fertilized here and travel through the uterus and end up here? That's the next theory we're going to discuss, yes?
External migration is?
Outside the uterus. Internal migration in the uterus.
In the uterus, correct. Internal migration is rare. Now there is one theory, Iffy's theory, quite interesting. Delayed ovulation and fertilization. Hormones are not suppressed, so menstruation occurs, and menstrual blood pushes the ovum back.
That's very interesting. So it has to be a perfect storm of events. You have to have irregular menstrual cycles and delayed ovulation, and then delayed conception, and then early period, and then it
pushing back.
Has there been any confirmed cases?
No.
No, it's just a theory.
No, because confirmation means Finding of corpus luteum.
Right, they'd have to do intense invasive studies.
Like that. Nothing.
There's no way of knowing. We can't retrospectively. But it's just an idea someone had, and maybe it makes sense.
If his theory, that's
Yeah,
good.
yeah. You think it's true?
It may occur.
May occur. Huh. Seems like it. Okay.
Tubal spasm can also cause ectopic, but it's just hypothetical. All the above factors cause delay in the passage of fertilized ovum, by which time it develops chorionic villi, and the tubal mucosa undergoes decidual reaction, and so implantation and occurs. Factors which favor ovulation factors which favor nidation in the tubes is tubal endometriosis.
Which is clearly obvious, right? If the uterine tissue in the tube, it's going to be a good area for the egg to implant, no?
Pathology, it is sites of implantation in the fallopian tube. Commonest is ampulla.
So the ampulla is up here, yeah?
Yeah. Commonest is ampulla. That is least dangerous here.
It's the biggest space, right?
Yeah. Isthmus is less common, but very dangerous.
Down here,
Since it's very narrow.
the narrowest part of the
Yeah.
tube.
Fimbrial,
Here.
there. Interstitial rare, only in 5% it may
Over
occur.
here, outside.
Changes in the tube. Hematosalpinx. Decidual reaction is poor and patchy, limited hyperplasia and hypertrophy of the tubal muscle. Stretching is more, so chorionic villi penetrate the musculature. Intramuscular implantation occurs, whereas in intrauterine pregnancy it's intradecidual implantation. So intramuscular. So invasion of blood vessels and choriodecidual hemorrhage.
Because the musculature is more vascular than the
Decidua. Further changes depend on mode of termination of pregnancy, whether it's abortion or rupture. Now, abortion usually occurs invariably between 6 to 8 weeks. Opposite tube, sympathetic hematosalpinx. Here there is bleeding in one tube. So, as a sympathy, the other tube also starts bleeding.
Right, I think that's so interesting because I never would have thought our ovaries are so smart. They're connected like sisters.
Because there's nerve connections. No?
So we have the brain, we have the gut brain, and we have the tube brain.
Changes in the uterus. Uterine size is enlarged because of estrogen and progesterone and HCG. There is increased vascularity, hypertrophy of all tissues, decidual reaction in endometrium, area stellar reaction of endometrial glands in 10 to 15% cases. That is mixed pattern of atypical proliferation and secretory activity. The epithelial cells are enlarged and with hyperchromatic, bizarre shaped nucleus. Cytoplasm vacuolated and foamy. These changes, except for the secretory activity, are rather suggestive of malignancy, are due to unusual response to steroid hormones. Not always peculiar to ectopic pregnancy, can occur in normal pregnancy. There's an early pregnancy in vesicular mole. The decidua is maintained until some time
Until some accident overtakes the
until
pregnancy.
some accident overtakes the pregnancy.
The decidua separates.
The decidua separates and is discharged from the uterus either as a whole cast or in fragments. Decidual separation is accompanied by slight and continuous uterine bleeding. Prior to this and while the pregnancy is alive, the patient is amenorrheic.
So it's sometimes self-limiting. Sometimes the tube sheds itself. Yeah?
It's not self-limiting.
Sometimes the ectopic pregnancy resolves itself. It doesn't.
Very rare, very rare.
Well, it says that the tube sheds the decidua like a cast.
It sheds like a cast, no doubt, but inside damage has occurred, no. Bleeding has occurred.
I see.
Pelvic hemorrhage would have occurred. So that symptoms will be there. No?
Okay. So this is just a precursor to the other major event. It's not like the tubes are shedding the pregnancy itself.
Mode of termination of the pregnancy. Because the tube is capable of only limited distension and is unable to provide for secure placentation, pregnancy is terminated usually before 6 to 8 weeks. In isthmic implantation, even earlier, sometimes even before amenorrhea, in interstitial pregnancy, continues for a longer time, 12 to 16 weeks, because myometrium is capable of distension. The following are the modes of termination of the fetus: tubal abortion, tubal rupture, tubal mole formation.
Are mole formations more common in the tube than in intrauterine? Hydroform mole. It's more common in the tube, or it's the same thing?
No, it's less common.
Less common. Right. Have you seen one? Hydroform mole in the tube?
Yeah. Mole, not heteroform mole. The whole pregnant sac becomes mummified, calcified like that. Like a mole it becomes.
So the most common form of termination is
Here I am.
here.
The commonest is tubal abortion. Occurs when implantation is in the ampulla or infundibulum, near the peritoneal cavity.
Upstairs.
And that abortion can be complete or incomplete. Incomplete is common. That's why pelvic hemorrhage and symptoms develop. Investigations.
Well, we have to talk about the other types of terminations. So we just talked about tubal abortion. We have to talk about tubal rupture.
Tubal rupture occurs in...
Here. So finish talking about tubal abortion. The choriodecidual hemorrhage occurs.
OM is separated from the attachment, bleeding into the peritoneal cavity. There is peritubal hematocyl and pelvic hematocyl. Embryo expelled into the peritoneal cavity. That may be complete or incomplete.
So
tubal abortion, rupture.
Tubal abortion is the most common termination of ectopic pregnancy.
Yeah.
But it can still cause hemorrhage.
It will cause.
Yeah.
Because blood trickles, no?
But the most dangerous is the next
Tubal
form.
rupture is dangerous. In 30% of the cases, it's tubal rupture. Occurs in isthmic and interstitial implantation. As the isthmic is narrow and less distensible, the wall is easily eroded by the chorionic villi. Intraperitoneal rupture common into the peritoneal cavity. Partly expelled, so bleeding occurs continuously, can occur, and pelvic hematocyl can form. If the rupture takes place on the inferior aspect of the tubal wall, it is intraligamentary rupture. That is within the two leaves of the broad ligament, interligament.
So, here's the broad ligament. So the rupture happens where?
With the two layers of the broad ligament.
It gets stuck in between. That's more dangerous or less dangerous?
It's not that dangerous
Oh, it can just happen.
because it's sealed. It seals the hemorrhage bleeding, because two layers are there.
Right, but won't the two layers fill with blood like this?
Yeah.
No?
Now they will, blood goes on accumulating, but because of two layers, the bleeding can get arrested.
And it doesn't go into the peritoneal cavity causing pain.
That is once that broad ligament also ruptures.
That can rupture and then be late. So broad ligament can mask some of the symptoms. So it's not good. It's more dangerous.
Yeah. No, it can not that dangerous.
Because the tube ruptures, and instead of the blood going to the peritoneal cavity causing pain, it just goes to the broad ligament and
So
it's
that-
hidden. And then at that point, by the time that ruptures, there's already been excessive bleeding.
Yeah.
More bleeding is more.
Yeah. Bleeding is not more. The two layers of the broad ligament will cause pressure, and hence bleeding can
I
get
see.
arrested.
I see. It almost acts as a tourniquet.
Yeah, like this, the layers are like this, and bleeding occurs here. But these are the two layers.
Right.
These can
Compressing.
compresses.
It's putting compression on
The bleeding points.
I see. Okay.
As the isthmus is narrow and less distensible, the wall is easily eroded by the chorionic villi. Intraperitoneal rupture common, partly expelled, so bleeding can occur into the peritoneal cavity, pelvic hematocele can occur. If rupture takes place on the inferior aspect of the tubal wall, intraligament rupture, that is within the two leaves of the broad ligament. If the rupture is slow process and the embryo along with its content, intact chorion, sometimes escape and gets attached to the neighboring structures, and new vascular connections can develop,
So it could double implant, one from the tube and then it bounces off and hits somewhere else.
and that results in secondary abdominal pregnancy, intraperitoneal pregnancy. And secondly, into the two leaves of the broad ligament pregnancy, that is extraperitoneal rupture. Intraperitoneal is, it is in the inferior aspect but within the peritoneal cavity. Extraperitoneal becomes within the two leaves of the broad ligament if the ovum escapes. That's extraperitoneal.
You gotta keep the ovums under control. No rogue ovums.
Fate of abdominal pregnancy, secondary abdominal pregnancy, death of the worm and complete absorption. That's one common thing which occurs. Placenta may separate.
So that's self-limiting. Death of the ovum and complete absorption. Self-limiting.
Yeah.
If the bleeding is under control.
Placenta may separate and severe bleeding can occur. And if placenta remains there for a long time, infection, fistula formation between intestines, bladder, vagina, and umbilicus.
Have you seen a fistula from Ectopic? No.
Dead fetus may be mummified, calcified, rarely continues to term. Spurious labor starts. If not delivered, death of the fetus
And obviously that's a C-section.
due to placental insufficiency.
Emergency C-section.
Yeah, fetal malformations are common because of scanty liquor and chronic placental
You've
insufficiency.
never seen a term baby.
No. So these are all rare conditions. Tubal mole due to repeated small hemorrhage and in the choriodecidual space, separation of villi, ovum dies, malformed in 80%, surrounded by blood clot, may be completely absorbed, expelled through the abdominal ostium, sometimes calcified, forming a mole. Fate of the fetus, death is the rule due to placental separation, and that can get absorbed, mummified, calcified, and lithopedion formation. Survival to term is rare. Now, clinical features of ectopic pregnancy. Clinically, two distinct types: acute or dramatic, second, subacute or chronic, depending on the mode of termination, whether it's abortion or rupture. Then, clinical type again depends upon amount of intraperitoneal bleeding.
And is the amount of bleeding positively correlated with the gestation? Higher gestation, more bleeding, or not necessarily?
No.
So let's say a 4-week ectopic pregnancy that dies off has less bleeding than a 10-week ectopic pregnancy.
Not like that.
You don't think so?
No.
No.
Irrespective of
Gestation age. Bleeding is bleeding.
now, clinical features of ectopic. Clinically, two distinct types are
We
recognized.
already spoke about that, so let's put on here. We just talked about the amount of intraperitoneal bleeding. causing-
Okay. Subacute or chronic is the commonest. Usually follows tubal abortion. Clinic features are due to pelvic hematocele. Symptoms: patient is in reproductive age, history of infertility, short period of amenorrhea, 6 to 8 weeks, and symptoms of early pregnancy will be there. Abdominal pain,
Maybe.
and
Maybe acute or in attacks.
in acute attacks,
Acute attack.
and associated with fainting, that is the fainting that is common. Fainting attacks, from which she recovers quickly, followed by persistence of dull pain in the lower abdominal or colicky
And this is
pain.
happening over days, yes? It happens over the course of a few days, a week,
And short,
a few hours.
every hours. Within 24 to 48 hours, they are shifted to a better hospital and treatment given. And colicky pain of lesser magnitude.
That's right, lesser magnitude.
Colicky pain of lesser magnitude.
So we spoke about abdominal pain, symptoms of early pregnancy, acute pain attacks, and fainting attacks,
And that
followed by dull colicky pain.
pain, colicky pain.
And then the pains of lesser magnitude after.
After that fainting attack.
And the fainting attack is from a vasovagal
Pain
response.
is due to
Right?
distension of the tube and peritoneal irritation.
The fainting. I want to go back to the fainting attacks for a second. The fainting attacks happen because of vagal nerve
Nerves,
stimulation. Yeah.
peritoneum full of nerves. Vaginal bleeding, sooner or later, vaginal bleeding occurs. Small in quantity and altered colored blood. Sometimes decidual cast, that's fleshy mole, may be expelled.
What color is the blood? Dark brown?
And bleeding precedes pain. Bleeding precedes pain.
Right, I remember. That's important to remember. Bleeding
Yeah.
precedes pain in ectopic pregnancy. And this,
Whereas abortions,
yes, pain.
pain is the first.
But with the color of the vaginal bleeding, it's dark brown in color?
Dark brown.
Dark brown. Almost black?
Yeah. That's how we diagnose ectopic. When we do colpocensus, we take some blood and put it in a small bottle, keep for some time. That blood will be dark, altered colored, and after some, it doesn't clot
It won't clot.
because already lot of fibrinogen is used because there's lot of bleeding. So clots have formed in the peritoneal cavity.
I see. So normal menstrual blood will clot. blood from ectopic pregnancy hemorrhage will not clot. Fun fact.
That is because all the fibrogen has been utilized.
Right. Inside it's trying to clot, clot, clot. Ah, interesting. So acute bleeding precedes pain.
Yeah.
Other symptoms of acute ectopic pregnancy.
Other symptoms are bladder symptoms like irritation, frequency, dysuria, retention of urine, sometimes rectal tenesmus. One patient we had, there was rectal tenesmus in infected hematocele, and on this we could suspect ectopic.
Like rectal.
No, that should feel like
That needed fast
defecate.
motion, pressure. Like, but she couldn't pass anything. She
That's the
just felt
symptom she came with.
pressure on her rectum.
That was the only symptom for which she came. I had many cases, no? That's why.
And
Sometimes rectal tenesmus in infected hematocele. Rise of temperature sometimes because of infection or due to absorption of the products of degenerated blood accumulated in the abdomen. Now, what are the examination findings? Patient looks ill, pallor not proportionate to the amount of vaginal bleeding, because lot of blood would have accumulated in the peritoneal cavity.
Right.
So,
She also has tachycardia, right? She has lots of blood loss. Her
tachycardia, sometimes in shock, but not common as in acute variety. Acute variety, they are always in shock.
Okay.
I've seen many coming with shock.
Yeah.
Per abdomen, tenderness and muscle guarding in the lower abdomen, especially on affected site. Mass may be felt in lower abdomen, irregular and tender, because of pelvic or peritubal hematocele. Pelvic or peritubal hematocele, see this blood.
Here, this side.
Accumulates in the, where is that pelvic?
This is the broad ligament. The round broad ligament. Here's the round ligament. What are you looking for?
No, pouch of Douglas, where is it?
It's not here. It's up here. I don't think it's on this diagram.
It is in transfer section, no? That's why. Here, somewhere here only pouch of Douglas will be. It's behind this, pouch of Douglas.
Behind. So the uterus sits in front with the ovaries, and behind is the pouch of Douglas.
Pouch of Douglas.
Between that and the lower segment of the bladder.
Yeah.
Oh. So she has tenderness, muscle guarding in the lower abdomen, infected side.
Mass may be felt in the lower abdomen, irregular, tender, because of pelvic and peritubal hematocele, clotted or organized blood there. Sometimes Cullen sign, bluish discoloration around the umbilicus.
Right.
Bimanual examination extremely tender, movements of the cervix tender, irregular tender mass in peritubal region. Uterus must be pushed to the opposite side.
And we have to be very careful with bimanual exam.
Yeah, then
You finished here? Weight increase. Is that from the extra weight of the blood?
uterus is enlarged.
Oh, uterus is enlarged.
Your weight, your thing. In early cases, before rupture or abortion, pulsatile mass in lateral fornix may be felt sometimes, occasionally. And when you do per speculum, fullness in the pouch of Douglas, because pelvic hematocele. Examination under anesthesia not recommended because of the danger of rupture, and tenderness can't be elicited. Acute is due to intraperitoneal bleeding. Less common in 30% due to rupture usually, and in tubal abortion. Acute variety can occur in tubal abortion with massive intraperitoneal hemorrhage. Then,
or tubal rupture.
yeah, all these patients are in the reproductive age, and infertility would have occurred, would be the sometimes history of infertility. Onset sudden and dramatic in the acute variety. Short period of amenorrhea, because termination occurs because of tubal stretching or in the vessels getting penetrated. Manifestation early.
So could she still have a menstrual? She could still have a period.
No, because it's the bleeding there, not the period. It's not her period. She would have a short period of amenorrhea. Then bleeding. Then bleeding. Then abdominal pain may or may not. No, amenorrhea may not be present in about 25% of the cases. Abdominal pain is severe and colicky, and in between colicky pains, patient is in agony, fainting attacks common, and syncope are due to vaginal bleeding.
Syncope due to
irritation of the peritoneum.
Vasomotor disturbance caused by irritation of the peritoneum. And then lastly, vaginal bleeding. But I have a question, Dr. Girma. So let's say you have an ectopic pregnancy, okay? The decidual reaction happens. What's the uterus doing? So it depends if there's a corpus luteum or not.
What depends?
So...
No, what did you just ask?
So I just answered my own question. I said, so the uterus and tube are still communicating, right? The decidual reaction, the corpus luteum is still providing progesterone, right? Which is suppressing menstruation. So she's not going to have a period no matter what. Any bleeding is going to be bleeding from rupture or abortion.
Yeah.
No bleeding will ever happen from the uterus thinking it needs to shed its layer, because the corpus luteum is keeping the uterus nice and fluffy because it thinks it's pregnant in the uterus, right? The uterus stays pretending it's pregnant, but the egg is not in the uterus. Correct. No period can happen.
No.
Okay.
On examination, patient is usually in shock in the acute variety. Pallor, extreme pallor. And pallor is out of proportion to the visible vaginal bleeding. Bleeding may be, because bleeding is mainly in the peritoneal cavity. Abdominal findings, tender, rigid, shifting dullness. Bimanual examination, very tender. Then if infection has occurred, then in symptoms of infected ectopic. Diagnosis of acute ectopic. Classic history of acute abdominal catastrophe, facilitating attacks of collapse, fainting attacks and collapse associated with intra-abdominal hemorrhage in a woman of childbearing age. Point to a certain diagnosis of ectopic.
So subacute and acute are very similar.
The difference is the rupture, tubal rupture will cause acute. Shock.
Immediate. Yeah.
Subacute also is they're in shock, but not like the acute variety.
Right, because tubal rupture.
But that's also dangerous. Subacute variety also is dangerous.
Because it's less severe symptoms. They're kind of, maybe this is normal, maybe it's not normal. That's why it's called subacute. There's no intense severity of in symptoms. Okay, I see. So it can also be dangerous because people brush it off like this.
Yeah. Tubal rupture in 30% of the cases.
We already talked about that one. We talked about this one. We talked about diagnoses. And what do you want to talk about?
Differential diagnosis.
You want to talk about differential diagnoses or investigation? or pathology of sites. We already talked about that. We already talked about this. We have investigations. Oh, this is
The differential
but where's
diagnosis.
the beginning? You don't want to talk about investigations first?
Investigations.
Here. Here we go. Page 3.
Differential diagnosis of acute ectopic. All causes of massive hemoperitoneum suddenly, perforating peptic ulcer, rupture endometriotic cyst, twisted ovarian tumor, acute appendicitis.
So of all these though, ectopic, perforating peptic ulcer, rupture endometriotic cyst, twisted ovarian tumor, or acute appendicitis, which is most common? What's the most common? Ectopic is most common.
Ectopic
Because this is rare. Twisted ovarian tumor, rare. Rupture of endometriotic cyst, rare.
no, they are not that common.
Right. Perforating peptic ulcer, rare.
Ectopic one is the commonest. Acute appendicitis also is common,
Right. So when,
but it's not.
but it's more clinically diagnosable because pain is
Correct,
limited to
correct.
one side,
Yeah.
and no vaginal bleeding with appendicitis.
Diagnosis of chronic ectopic. At times difficult because in 25% no history of amenorrhea and even vaginal bleeding, and in 15% apparently normal general condition.
So even if somebody comes in and says they just had their period, you should still do a pregnancy test. You can't rule out ectopic pregnancy without.
But if pain is there, then we should suspect ectopic. Otherwise,
Right.
it doesn't.
Right, but I think sometimes people say, when was your last period? And if it was recently, they're thinking it's not ectopic because how is their time? But we shouldn't do that because sometimes amenorrhea is not even noticed. Right, this can happen before their first missed period. Ectopic.
But amenorrhea is not a classic symptom of ectopic. It may
Right.
not be there.
But ectopic pregnancy can happen before a woman misses her period.
Yeah,
Right.
this amenorrhea may not be there.
Exactly.
In 25% there is no amenorrhea.
So it's, when we do the differential diagnosis, we have to be careful and not just, well, she didn't miss her period, she's not pregnant.
She's not,
We have
no.
to. We have to
We have to be very careful.
thoroughly assess her pregnancy status beyond just LNP.
Now, differential diagnosis of acute ectopic. All conditions causing massive hemoperitoneum suddenly, perforating peptic ulcer, rupture endometriotic cyst, twisted ovarian tumor, acute appendicitis. These are the differential diagnoses. Diagnosis of chronic ectopic. At times difficult because in 25% there is no history of amenorrhea and even vaginal bleeding, and in 15% apparently normal general condition. Differential diagnosis. Abortion of an early intrauterine pregnancy. Points against are vaginal bleeding precedes pain, no fainting attacks. Pallor is proportional to the amount of vaginal bleeding. Persistence of pain and uterine bleeding in spite of curettage for supposed incomplete abortion is often due to diagnosis of ectopic pregnancy. Clue to the diagnosis of ectopic. Persistence of pain and uterine bleeding in spite of curettage for supposed incomplete abortion
Right.
is often the clue to the diagnosis of
Right. It makes
ectopic.
sense. The pregnancy is going to persist when we do a DNC
Yeah.
because it wasn't intrauterine.
Pelvic infection. Points similar are irregular uterine bleeding, lower abdominal pain, tender and enlarged appendages. Points against are usually bilateral, no fainting or collapse, fever and leukocytosis, raised ESR, previous attacks present. Pelvic infection, many such attacks
Right.
may.
Over months or weeks.
Yeah, no pallor and amenorrhea not present.
The ESR won't be increased with ectopic pregnancy?
Yes,
ESR is increased.
if ESR is increased, if it's infected. Otherwise, pelvic infection ESR is raised, but in ectopic is not commonly raised unless there is superimposed infection.
Inflammation won't raise ESR? Inflammation?
That will cause raised ASR.
So isn't ectopic pregnancy caused
Inflammation is not there.
not until rupture?
The inflammation doesn't normally occur. Only
Even
when
when
there's
the tube ruptures?
no, infection is not.
Inflammation.
No, it's not not inflammation.
When
Only,
a tubal muscle is rupturing, there has to be some inflammation.
no, infection is different from.
I know, but I just asked you. ESR increases
Is will
with
raised in.
inflammation too, though. It increases with inflammation.
Yeah, but that's not common
Okay.
in ectopic. Appendicitis points against history of previous attacks, nature of pain. There, the pain starts in the right iliac fossa and migrates to the around the umbilicus. No pallor, no amenorrhea, pelvic findings negative, no menstrual disturbances, vomiting predominant. Twisted ovarian tumor. Points against are history of mass, absence of fainting, no pallor, mass well defined. Retroverted gravid uterus with retention of urine, with impaction and threatened abortion. Points against no pallor, no fainting attacks. Pregnancy with tumor, rupture of endometriotic cyst, or can also be the differential diagnosis. Investigations. The most common investigation is colpocentesis or culdocentesis. Ultrasound. Then, and if there is bulging of the pouch of Douglas, put a needle and you will aspirate altered color blood which doesn't clot. If there is doubt still, we should proceed immediately to laparoscopy.
Right.
Pregnant.
This should be the first thing should be a urine pregnancy test and blood test, no? Total count.
Yeah. This is correct, but these are not very specific tests.
No, they're not. But that's the first thing we're going to do if somebody comes in with severe.
And they are. In infected ectopic, they are raised. Pregnancy test will be positive.
And if she's having peritoneal bleeding, her CBC, her hemoglobin is going to be down, no?
Yeah, that will be down. Laparoscopy is the commonest investigation done, and simultaneously treatment can be afforded through the laparoscope.
Can you see peritoneal hemorrhage on ultrasound? Can you see?
Yes.
You can see it. What does it look like?
There will be fluid there, and hemorrhage, blood can cause, what to say, the picture will be,
The bleeding, the picture will do it. Let's see if we can see a picture. Because usually tissue is white, yes? Fluid is black. So you'll see a lot of more fluid. What does it look like? It's not done. You're thinking of a specific word. What's the word? You'll be able to see it. Yolk sac in the tube?
that's before rupture, early pregnancy, if you are
Early
diagnosed.
diagnosis. But after rupture,
No.
it's floating somewhere. You can't see it. So it's just fluid. You just feel fluid. You see
Fluid,
fluid outside.
but blood will present that white specks, no?
White.
White.
Just because the way the ultrasound waves hit the blood, the RBCs.
RBCs.
I see.
So that's how water in the pouch of Douglas and blood we can differentiate like that.
We're so smart. Very smart. We're smart.
Me?
Both of us, you and me.
You also.
Okay. So
ultrasound we can diagnose blood. Then we put a needle there and you can aspirate
it.
blood which is dark, altered color,
And then we
dark,
do our science experiment, which we see if it's clotted or not clotted.
doesn't clot.
Oh, doesn't clot.
Then if there is doubt, even then if there is still a doubt, then you must proceed to laparoscopy. That's only when necessary.
But it's usually all of these investigations usually tell us ectopic or not ectopic. There's usually very little doubt that we go in
Yeah.
with surgery not knowing what to expect. Usually that's more of a treatment mode.
Pregnancy test is of limited value. Management, treatment of shock, blood transfusion, laparotomy as early as possible, and after opening the abdomen, immediately, many cases I have done, immediately put a clamp and arrest the bleeding, salpingectomy.
On the tube.
There.
You're only in the
Yeah.
isthmus? Clamp.
Correct. Put a clamp, bleeding stops immediately, and two of my patients were in utter shock. And as soon as I put the clamp, bleeding stopped and immediately her PP started rising.
Okay.
We had many ectopic.
How long can you clamp the isthmus for before there starts being damage to the tube?
No, that is if you want to preserve the tube, if she doesn't have children.
So you can clamp it for how long?
No, not long. We cannot clamp.
5 minutes.
You
You can
cannot.
clamp. But to stop the bleeding, you have to clamp.
That is we have to, when
If
you're
she's in
treating,
shock.
when you're treating, if you're the salpingectomy, you'll cut the tube. So that time you can clamp.
Right. But if you're trying to save the tube, you shouldn't be clamping the tube.
No,
That
no,
can damage.
because the blood vessels will be also clamped.
We don't want them to get destroyed. So if you were going to save the tube, what would you do?
Then we have to do that. So laparotomy when we do, when we know it's ruptured, then the treatment is salpingectomy, and some people also commonly do oophorectomy.
Because if you're taking the tube, why leave the ovary?
Because they are scared of repeat ectopic. Nowadays we don't. Nowadays we are not. We don't do.
Right. You leave the ovary.
Yeah.
Hysterectomy.
And tubectomy, salpingectomy होता है. Hysterectomy in interstitial pregnancy. Because it's difficult. No, interstitial pregnancy is in the bicornuate horn, rudimentary horn of a bicornuate uterus. So, because it's difficult to do salpingectomy there, it just hysterectomy in such cases, if bleeding is not arrested, hysterectomy. But it can be possible to.
Can you ever, so in a bicornuate uterus, the rudimentary horn, can you ever just take off the rudimentary horn and close off the uterus?
That has to be done. It can
You
be
can
done.
do it. And then they can go on to have a normal pregnancy?
No, how can they have pregnancy? Because
so bicornuate uterus, 2 horns.
other horn they can have.
Yeah.
They can have.
But you take off one horn, you still have to close off,
Yeah.
and they can go on to have a normal pregnancy. Not in that horn. The horn's gone. Hornectomy, we'll call it.
The other horn is there. No? They can have. They have conceived also. Like that there are.
They have an increased risk of uterine rupture because of uterine surgery?
No.
No. Excellent. Normal birth for them too. Okay, so
But in interstitial pregnancy, hysterectomy may have to be done.
okay.
Conservatory surgery for repeat ectopic, salpingostomy, milking is not done now. The recent advances in ectopic pregnancy, early diagnosis, and now early diagnosis is possible because of the measurement of beta HCG.
Right, and at point of care
Yeah.
DPTs.
And conservative treatment. So surgical treatment, medical line conservative
And
to save the tube.
Now people are more well connected to antenatal care. Right? If they have pain, they've been trying to get pregnant, they're going to come in. They know.
Oh yeah.
Okay, so we talked about differential diagnosis.
Wait,
we
no.
talked about investigation.
No, but
treatment.
this thing in under Conservative surgery, wait.
That's number 1. This is number 1 too. Same.
No?
Yeah, same.
Wait, I'll tell you something. Now, conservative surgery is possible because of rapid assay beta HCG and doubling of the main aim is to preserve the other tube because repeat ectopic is common, no? Same the pathology persists, no? Infection is the etiology, persists, so repeat ectopic can occur. So we aim at conservative surgery now.
Right.
And what conservative surgery means? Sulfingostomy.
What exactly is a sulfingostomy?
But it'll make a linear incision, suck all the products, and leave it open, or sometimes we switch
And
it.
this is prior to rupture. You can only do it prior to
That's
rupture.
why early diagnosis is very important.
Right.
How
Because
to diagnose?
after rupture, you can't be doing that.
How to diagnose early?
How do we do it?
By beta HCG.
Yeah, and no gestational sac seen in the uterus on ultrasound.
Ultrasound. And
So we can diagnose before she even has symptoms.
yes,
Most cases are now done that. Most cases in suburban areas are early detected. You think?
no.
There's still late detection coming?
In villages, it's still late
Right,
dissection
I
in
said
India.
suburban areas. Suburban. Most cases are early.
But in institutions and all, early diagnosis is possible.
Right. So we talked about the treatments. The treatment and investigations were kind of
And
together.
see, diagnosis is estimation of beta HCG and beta HCG doubling of the titer
Right, in normal
once in 3
pregnancy-
days. Once in 3 days.
In normal pregnancy, it doubles.
Yeah,
In ectopic pregnancy,
it doesn't double. It's less
Low.
than double. Ultrasound of better resolution. So early diagnosis by estimating beta HCG and observe, repeat it after 3 days. It should double if it's intrauterine pregnancy. Otherwise, in ectopic, it doesn't double, less than that.
Right, but are we waiting 3 days if we're suspecting ectopic pregnancy? We're not likely to wait for 3 days if we suspect ectopic pregnancy.
Under observation, she'll be under
To
observation.
stay admitted at the hospital. Do you want to talk about conservative treatment of ectopic? We talked about surgical treatments.
And medical line of treatment.
Ah,
That's with methotrexate.
yes, methotrexate. And there's one other, and calcium. We give them folate. Remember, we give methotrexate and folate.
Folinate.
Folate, yes, together. But we had discussed this last time, and I don't think we're going to get into it because I don't think it's commonly used anymore. That sometimes you would actually inject the ovum with prostaglandins or other medication, and then you'd inject the corpus luteum to kill the pregnancy. But that's no longer very common. But it's interesting.
Still, some people do it.
You've done that?
No.
No. It's under laparoscopic surgery because you need. It's like a video game. Insert into the ovum, shoot the ovum, insert into the gestational sac.
But it has been tried. Elsewhere also they have
Yeah,
experimented.
they've tried a lot of things in obstetrics.
Yeah.
So methotrexate, we have to be careful because why? What is methotrexate? Methotrexate can damage other tissues too, right? Methotrexate works. The mechanism of action is by killing rapidly.
Correct, but
rapidly
that is
duplicating
not that
DNA.
common because it's not such high dose, no?
It's a low dose.
Not that high dose. So it won't kill the other tissues.
Just the sensitive DNA of the embryo. Okay. Is there anything else you want to speak about? One dose methotrexate or 2 doses, typically? And that the methotrexate in an early diagnosed ectopic can be done at home, right? Outpatient. We send the patient home.
Home, no.
We inject methotrexate, we send them home.
No, we keep them. Because any time again bleeding can occur. No?
But this is early diagnosis, before rupture, before abortion.
Sending home, no.
Pretty sure we did that here.
Here you do.
Oh, early diagnosis, no symptoms, maybe
But you have confirmed ectopic.
someone, yeah, recently.
Confirmed ectopic has been sent home. Very dangerous. Anytime bleeding can be massive. Shock and death can occur. The main aim of treatment nowadays is to reduce mortality.
So ectopic pregnancy or admitting them until symptoms, until
Some
resolve?
event occurs. Yeah.
So how can we, is methotrexate 100% effective?
No, if it after methotrexate, if beta HCG is is positive,
We have to keep,
and if it doubles,
we have to
then
keep
again,
testing.
yeah, we have to do a
And we
next.
keep them in the hospital the whole time? That's like a 1-week hospital stay.
It's better.
But not everyone can do that.
That is, if it's very costly, so we.
Does IVF increase your risk of ectopic?
Hmm?
IVF conception, does it increase your risk of ectopic?
Yes,
Yeah, because the ovum,
because if we may push. It depends upon how we introduce the fertilized ovum, how it implantation will. It can.
we've seen a risk with an increase in incidence of ectopic pregnancy
PID.
with birth control and before. So conservative lifestyles before, right, was less intercourse at a young age, right? Now times are changing. We live in a more global mindset, free body world where we're taking birth control to prevent pregnancy, right? And so that increases the risk of STD transmission, right? If we're being more sexually liberal, we have the higher chance of contracting an STD. More STDs mean more pelvic inflammatory disease. More pelvic inflammatory disease, more risk for
That was the main reason for rise in ectopic. But now STDs have reduced almost 0%.
I don't think almost 0%.
No?
No. You know, in America, there was this one study that came out that STDs were on the rise in nursing homes. No, you don't have nursing homes here, but in America, we have homes for older people. But their families can't take care of them. They send them to a nursing home. And the old people are having intercourse. And there's a big rise of gonorrhea and chlamydia in the elderly population.
Oh.
STDs are very common, I think. HPV, gonorrhea.
Your STDs are now very less common.
Well, maybe in Darwin, but not in Bangor.
Sure. Now people take treatment early.
Right, but it's still, some people take treatment early.
Because I have not seen any case of gonorrhea and all. In my latter half of the service.
Maybe gonorrhea has come down, but chlamydia
Chlamydia is increased.
But gonorrhea is more likely to cause PID because it's a more severe infection. Chlamydia is more benign.
And pus forms no, in gonorrhea. And painful. Gonorrhea is painful.
More inflammation in gonorrhea. Chlamydia is more transient. We've devolved our conversation to STDs. Is there anything else you want to discuss in ectopic pregnancy? What is this? Something in Asian women.
Higher in Asian women.
Molar pregnancy. We're talking about HCV here. I don't know what that's about. Anything else you want to discuss?
Discriminatory zone of HCG. 6,000 to 6,500 milli international units. This is the discriminatory zone. Combined use of ultrasound and HCG, better diagnosis.
Right, so if it's below 6,000, you can expect
6,000 to 6,500, that is a discriminatory zone. In many ectopics, this is the commonest level we get.
Level. And in a normal pregnancy at the same gestation, what's the level?
And after by 66% in normal pregnancy, over 48 hours.
Right, so let's say we're doing, but that's 48 hours, right? So we're observing the patient for 48 hours, but there's still a chance she has ectopic pregnancy. We do one initial HCG and it's 6,000 to 5,500. In a normal pregnancy at early gestation, what's the normal range of HCG? Let's say, like, this doesn't mean much unless we know the gestational age, right? HCG and the gestational age go hand in hand. So this could be normal for a normal pregnancy at 4 weeks. No?
But doubling we should see.
Yeah, we should see doubling, but this one value doesn't mean much in HCG.
So in this, between 6,000 to 6,500.
Wait, but when? What's the gestational age?
In normal pregnancy, and repeat after 48 hours,
it should
increase by 66% at least. The increase is less than this in 87% cases. False rate. Intrauterine sac. The Kedar discriminatory zone. Intrauterine sac is present and the levels are between 6,000 to 6,500.
So you see a sac inside. It's 6,000 to 6,000.
Abnormal pregnancy, missed abortion, or ectopic pregnancy.
You'll see a sac in the uterus with ectopic?
No, that is normally is talking.
What's it called? Kedar.
Kedar's discriminatory zone, HCG zone. That is 6,000 to 6,500. That's the zone.
Right, but you get what I'm saying? The zone doesn't matter if we don't know what the gestational age is. Oh, I see. So we should see a sac at that HCG.
Normally.
No.
If you don't see, then
exactly. So it's not about gestational age, it's about ultrasound and HCG together. And we're looking at it like this.
Correct.
And it could happen at 4 to 6 weeks gestation. And if it's 6,000 to 6,500 and there's no sac seen within the uterus, then we suspect ectopic pregnancy because the level is high enough to sustain a pregnancy, but there's no sac in the uterus. I see what you're saying.
Normally sac should appear at that level.
I see. Got it. I didn't know we were also looking at ultrasound. I thought we were just taking HCG. You know? Okay. Anything else you want to... Want to discuss more about methotrexate? You want to say anything else about methotrexate?
Methotrexate, wait.
This side, this side, this side, this side, this side. We talked about that. I talked about that.
Methotrexate is there, I think, in that.
Yeah, somewhat. It's
there?
It's there. Medical management. Medical management is rapid growing as a treatment option for ectopic pregnancy. The commonest drug is methotrexate and is very effective in treatment of early ectopic. It's made feasible.
Possible due
the
to
ability to diagnose early. Right, so this is where the discriminatory zone in ultrasound comes in. We diagnose it early, we give methotrexate, we prevent any complications. But if we diagnose it late, laparoscopic surgery, salpingectomy, tubectomy, things like that might be necessary.
Yeah.
Because we can't, we can't be treating we can't give methotrexate if the patient's not stable, right? The patient's in shock. It's not like we're going to give methotrexate.
Patient should be stable.
So the second common treatment is local injection of either methotrexate or prostaglandin E2
into the gestational sac.
That's what we were talking about earlier. But this is not very common anymore.
No.
Because this also involves invasive procedures, injections. Methotrexate has any sequelae for future pregnancies? Any side effects on the body that are long-lasting?
No, not with this dose.
Okay, it's low.
The dose what you saw hydrated hormone, that can cause.
Or for methotrexate for cancer.
Here it is, I think 12.5 milligram, not we.
Now, what's this Foley bulb? Oh, you put methotrexate in the Foley bulb into the intrauterine cavity, and it flushes into the tubes. Huh. But oral methotrexate is the most common, I think so.
Well, no.
Or sorry, IM. Talked about this already.
All this are so perfect in my student days.
An intrauterine pregnancy should be identified within 39 days from the LMP. If a pregnancy does not occur within 6 months, this is for follow-up. If someone were to get pregnant again, we need to closely assess them. You said something interesting before. I thought because someone has an ectopic pregnancy, that increases their risk of a previous ectopic pregnancy. But it's not just that they had the ectopic pregnancy; it's the pathologic disorder that caused the first one. It's not. Sometimes ectopic pregnancy can be a one-off, right? It was a fluke. We don't know why it happened. But is it a majority of the cases have some pathologic issue? The cilia are not functioning well.
Or kinking of the tubes.
Kinking of the tube. That's most common?
Not common, but infection.
Right. And once you damage the cilia and the fallopian tube, they don't come back. Right? Once they're dead forever. So PID is very serious.
Yes.
It can cause lifelong reproductive issues. Safe sex is key.
See here.
So this is talking about BNC and HCG.
When mass is less than 3 centimeters,
And no cardiac activity.
non-laparoscopic medical treatment with methotrexate. This is the case. These are the fit criteria for.
Right. If this, then this.
And then close follow-up.
You usually see cardiac. You can see cardiac activity on a tubal pregnancy.
No, one case we suspected that it was cardiac.
The pulsing.
But if the patient is presented before any symptoms, then I think routinely if you do. But maybe now it's possible because routinely follow-up is done. See, so many notes I've done, but now I am not aware of.
This is interesting. Ectopic pregnancy, a study
Reappraisal stud 3.
of etiology.
Major problems: increased death rate. 2/3 will ever have a child. Will have and one in 10 will have a second ectopic. But that's older.
Yeah, that's all information. I have a question for you. Can you tell me the pathophysiology behind? When IUD is in place, women are likely to have an ectopic pregnancy because there's a physical barrier to implantation in the uterus. What about post-IUD removal? Are women more likely to have ectopic pregnancies? It depends if there's infection when they have an IUD.
Infection.
But IUD in and of itself can cause inflammation in the uterus, or if there's no infection, there shouldn't be any inflammation.
Usually it doesn't cause inflammation, but if there's no infection, I don't think ectopic increases.
Okay. It's just when the IUD is in, if for some reason the sperm fertilized the egg, there's a physical barrier to the egg.
That can cause ectopic.
But that means, but explain to me how it works though, because the egg doesn't go in the uterus and go back up the tube, or does it? It can do that sometimes. It comes into the uterus, it's like, I don't want to be here, and goes back in the tube.
Like Fifi's theory.
It gets pushed back in from physical obstruction.
That can be a possibility.
Ovum hits the IUD, goes back into the tube. Like one video game, ping pong.
Yeah.
Anything else you want to mention about ectopic pregnancy?
No. Here also actually there's lots, but I'm not aware of.
I think this just goes deep into the weeds. It talks about prostaglandins, talks more about HCG, but I think for now you've covered a comprehensive, superficial level of information. Yeah. And I know you like this topic because you enjoy topics that early diagnosis and prevention is key. Because in theory, we can eliminate acute ectopic pregnancy if we have early diagnosis and detection and treatment. Right? Same thing with preeclampsia.
Mortality can be reduced.
Yes, exactly. India has a higher rate of mortality associated with ectopic pregnancy because the state of
developing countries it is there.
Yeah. Do you feel like India has more than other developing countries?
No, India is far advanced now.
Okay.
So it's not that common.
The government has a lot of initiatives to encourage women to seek out antenatal care. And there's more education about seeing the doctor or the midwife.
Yeah, now they're everywhere compulsory visits are made, no?
Sometimes people come to the doctor too much.
Here, of course, in America, hardly any doctor is available for any problem is there.
Because of insurance.
But here it's
there's a doctor on every street corner. Do you have a specific ectopic pregnancy case in mind that you want to discuss?
No question or specific. They're all almost same.
Well, like a severe case.
Almost all are same type, no?
Have you seen some maternal death with ectopic pregnancy?
What?
You've seen quite a few maternal deaths?
That's ectopic. I've seen, but We used to interfere fast. We used to, so we were not. But still, I've seen 1 or 2 deaths.
So what's the time gap between somebody comes in with symptoms and they're in shock and when you can stop it? An hour, minutes. If they're in severe shock and you get confirmatory testing, you take them quickly to the OT, huh?
Quickly.
This is not hours or days. We're talking about minutes. Yeah, minutes save lives.
Yeah.
And they usually probably saw their village clinic first, and they got referred to higher level of care. So they've already been seen. It's already the early diagnostic testing has been completed.
No, by the time they present, sometimes it's very late.
Right.
But nowadays, because of many doctors are available,
Right.
and government has insisted on visits,
Right.
the ASHA workers,
Right.
and sophisticated hospitals with well-equipped
Right.
this thing is available. So I don't think it is now.
Less of an acute situation.
Early diagnosis is common.
So key points about ectopic pregnancy. Pain precedes bleeding. The discriminatory zone of HCG, 6,000 to 6,500, with no gestational sac seen in the uterus.
Yeah.
And early diagnosis and detection saves lives. Anything else?
And conservative treatment
Conservative treatment, you're right.
can save the fallopian tube,
Right.
and future pregnancy is not affected much.
Excellent. Thank you, Dr. Hirmath.
Thank
That's our
you.
next topic.
Thank you very much, Brianna. So next topic, I think we'll go to hydrated hormone.
I'm interested in that topic. I've never really researched much into it.
I have seen again plenty of cases.
Okay, excellent. We'll come back with pictures of hydrated moles next time. Thank you. See you.
So next time will be when?